Assalamu alaikum. The vast majority of sore throat cases are self-limiting. They would resolve within a week or so, even without treatment with antibiotics. And the vast majority of patients would not require any investigations. However, in some patients, when things are going wrong or when things are not going according to plan, then investigations should be considered. The vast majority of sore throat cases don't require investigations because the two most fundamental questions are answered on clinical grounds. The first is who needs the antibiotics can be answered by risk stratification of the patients using scores like the center or McIsaac or the fever pain clinical scores. And the other question, who needs the tonsillectomy, is usually addressed by the Paradise criteria. Both questions are answered by clinical factors or clinical criteria, and no investigations are needed. However, when things go wrong or when they are not going according to plan, like when the symptoms are very severe or persist despite adequate management for more than 10 days or 2 weeks, or when the symptoms are getting worse rather than improving, or then systemic complications are starting to develop, or when there is suspicion of secondary complications like rheumatic fever or acute glomerulonephritis. All these are sequelae of group A beta hemolytic strep infection, but identifying group A beta hemolytic strep is not the only clinical necessity. Other things can make the condition get worse, like maybe an infection by an Epstein-Barr virus or cytomegalovirus causing infectious mononucleosis. Scarlet fever may be developing, or a quinsy, Lemierre syndrome or Vincent angina may be the presenting condition. The first fundamental question in the management of sore throats, who needs the antibiotics, was addressed by several national guidelines, including the SIGN Guidelines 2010 onwards. It's based on distinguishing a viral from a bacterial etiology as the main reason for the infection and trying to assess the probability of the bacterial infection being caused by group A beta hemolytic strep by risk stratifying. The most common bacterial pathogen is, of course, the group A beta hemolytic strep, for which antibiotic treatment may be considered. There isn't a single symptom or sign that can establish the distinguishing criteria for the differentiation, but a combination of different signs and symptoms, different factors, have been useful in several clinical prediction schemes, including the Center Clinical Prediction Score and others. And the guidelines starting from 2010 onwards suggest that the use of such schemes can be useful in answering this question without the need for any investigations. This is a summary of the 3 clinical scores used to risk stratify patients with acute sore throat by assessing the probability of the infection being caused by either a beta hemolytic strep in general or a group A beta hemolytic strep in particular in the center and the McIsaac, and putting a certain probability to the grade from grade 1 up to grade 4 or 5. They all depend on clinical criteria, no investigations, mostly similar. Like, for example, the absence of cough would give you a point in the 3 of them because this is usually a sign of a viral rather than a bacterial infection. The presence of a fever would give you a point for each. But there's some differences, like in the McIsaac, it would give you a point if the age of the patient is below 15 and would subtract a point if the age is above 45 because bacterial group A beta hemolytic strep is rather not very common in this age group. And there are, for example, other differences in the fever pain. If you present very early within 3 days, then you take a point. But basically they are very similar. And then they stratify the probability of having a group A beta hemolytic strep. It was group 0. If you don't have any of these, it's very low, close to 0 at 2.5% in the center, but it would rise up to more than 50% if in grade 4. Something similar is happening in the 2 other. And generally speaking, if the score is below 2, then the possibility of a group A beta hemolytic strep is low and no antibiotics are advised. If it is higher, then one should consider whether to give an immediate prescription for antibiotic or a delayed prescription in the middle grades, for example. And because clinical decisions can be based on clinical criteria with no need for investigations, most national guidelines don't insist on having certain investigations for sore throats, including the German clinical practice guidelines and the UK national guidelines. There is no need for certain investigations, blood examinations or serology tests in the diagnostic workup in patients with acute sore throats that lasted less than 2 weeks, except of course if there are any red flags. When investigations are needed, one of the simplest investigations can be done as a full blood count. And in case of group A beta hemolytic strep, you would expect that these patients would have a higher total leukocytic count, mostly granulocytes, and they would also have a higher value of C-reactive protein. But the blood test in these cases has a low sensitivity and a lower specificity as well. ESR is not particularly useful, so it can be omitted because there is not much difference between bacterial and viral infections in the ESR rates, but C-reactive protein is important. C-reactive protein is just a non-specific marker released in the blood in response to various infections or inflammatory processes. Measuring it in acute sore throat can help in stratifying the risk of having a group A beta hemolytic strep and whether antibiotics are needed or not. We should generally expect a higher CRP in the case of bacterial infection causing the sore throat, but the cutoff point differs from a country to another. A German study, for example, suggested that the cutoff point is 35 milligrams per liter. Above that, it is probably a group A beta hemolytic strep infection, and below that, it is improbable. A Norwegian study suggested that the cutoff point is a bit lower at 25 milligrams per liter. The NICE guidelines, the National Institute of Clinical Excellence in the UK, in 2016 suggested that the CRP values should be a bit higher. They say that if the CRP is less than 20, then the probability of a bacterial infection is very low. If it is between 20 and 100, then there is a high probability, but if the clinician may consider giving a delayed prescription to be used only if the condition is getting worse. It's only if the CRP level is above 100 milligrams liter, in contrast to the German and the Norwegian studies, that immediate antibiotics should be started. A full blood count in case of tonsillitis caused by bacterial infection, you would expect a rise in the total count of the white cells, but mostly due to a rise in the neutrophil counts rather than lymphocytic counts. In contrast to certain viral infections, like for example the glandular fever, here the picture is reserved. You still have a rise in the white blood cells, but it's mostly due to a rise in the lymphocytic count in contrast to the bacterial tonsillitis count. The ratio between the lymphocytes and the total white cells in the cases of glandular fever would approach 50%. For example, it would be about half the rise is due to lymphocyte count. And in fact, the criteria to suspect glandular fever is that this ratio would be between 35 and 50%, and 10% of the lymphocytes would be atypical, and the absolute count of the lymphocytes should be above 4,000 plus other things. But these are the things you can get from a blood picture. If infectious mononucleosis is suspected, beside the full blood picture in which lymphocytes with a typical lymphocytes form would be seen, other tests would be also required, including, for example, liver enzyme tests. The transaminases would be almost uniformly elevated in the case of infectious mononucleosis, plus serology tests which would reflect the antibodies formed against the Epstein-Barr virus. In the very early stages of the disease and the incubation period or early in the acute phase, mostly there will be a rise of some heterophil antibodies and IgM antibodies that rises and drops quickly after the initial infection. Heterophil antibodies detection forms the basis of tests like the Paul Banel test or the monospot test to suggest if there is an infectious mononucleosis or not. The other immunoglobulins, IgG, would continue to rise after the infection and remains high in the blood for quite a while. Acute rheumatic fever is now uncommon in most developed countries. But rheumatic heart diseases that follows the acute rheumatic fever is still responsible for an estimated 300,000 premature or preventable deaths per year worldwide in other parts of the world. The antistreptolysin or titr that is frequently used to detect such a condition is not very useful in the workup of a sort of acute sore throat or acute tonsillitis, because it may reflect past and not present immunological events. And even if the throat culture shows that group A beta hemolytic strep with an elevated level of ASLO, it doesn't really indicate whether the presence of group A beta hemolytic is due to a recent infection or just a streptococcus carrier. And there is no evidence or any cut-off point that at a specific level in the rise of the ASLO titr tonsillectomy should be considered or not. Streptolysin S and streptolysin O are certain virulent factors produced by the streptococci, the group A beta hemolytic streptococci, and the body would form antibodies against these virulent factors, and these antibodies, for example, the antistreptolysin O titr, can be measured in the blood and can be estimated as an expression of an immune response to the group A beta hemolytic strep. But the level would be very variable. Only 40% of proven cases of group A beta hemolytic strep tonsillitis would have an elevated level of antistreptolysin O titr. The other 60% would not. Also, if the level is elevated, it may persist in asymptomatic patients. Patients who have not had the infections may have an elevated and persistently elevated ASLO level. Because of this high variability, it is difficult to be used as a diagnostic parameter in relation to tonsillitis and pharyngitis. Even severe cases of group A beta hemolytic strep infection in the throat may not necessarily followed by release of high levels of ASLO. ASLO level, if it is progressively rising repeatedly in repeated tests, may be of interest to cardiologists who are suspecting clinically a case of acute rheumatic fever, but it is not of much value in the management of acute or recurrent tonsillitis or pharyngitis. The high variability of the ASLO level would mean that if it is increased, you could not just assume that this indicates that there is an antibody protection against streptococcal infection that is mounting a good immune response. This is not reflected in just a high level of ASLO, and you could not tell from a high level whether there is an increased risk of acute streptococcal disease or not, and you could not tell whether there is an increased risk of a severe form, a purulent form, for example, of streptococcal infection or not, and you could not make a prediction regarding the streptococcal carrier state or if the patient is more contagious or not. That's why it is not very useful in the context of management of acute tonsillitis or acute pharyngitis. The question for whether a throat swab is required in cases of sore throats would differ between a national guideline and the other. The German clinical practice guidelines would consider it not routinely recommended, but there will be some exceptions for patients with signs of notifiable infectious diseases, like for example scarlet fever, or diseases requiring special treatment, or atypical pathogens are suspected, or if the patient has known immunosuppression. On the other hand, in the USA and the French guidelines, microbiological confirmation of the diagnosis is required either by a throat swab culture or a throat swab with a rapid antigen detection test. And the UK guidelines, starting from the 2010 SIGN guidelines and even in the NICE guidelines of 2019, they considered that there is insufficient evidence to support the routine use of throat swabs in case of sore throat, and they leave it only to some suspected cases and cases who are being considered, for example, for tonsillectomy because of recurrent severe episodes of sore throats. A throat swab would be indicated mainly, but not exclusively, to detect group A beta hemolytic strep, because in some conditions you want to explore whether the infection is done by other organisms or other beta hemolytic strep like group C or group G. But group A beta hemolytic strep is the most common. The incidence is between 5 and 36% of all infections. It's a higher incidence in children, where it's between 20 and 30%, and a lower in adults, between 5 and 15. The other organisms that you would find in a throat culture would include things like Lemierre, pneumonia, Mycoplasma pneumonia, Haemophilus, Candida, and Neisseria groups. The detection of either group C or group G beta hemolytic strep would also have some relevance in relation to the non-suppurative complications of beta hemolytic strep, not necessarily acute rheumatic fever, but mainly acute glomerulonephritis. The non-group A beta hemolytic strep include mainly the group C and group G streptococci. They are basically responsible for food-borne and waterborne outbreaks of pharyngitis. Some of these organisms are normal commensals in the throat, so it may be difficult to differentiate between a carrier state or a recent infection if the throat culture show C or a group C or group G streptococci. But they can produce an acute pharyngitis with clinical symptoms quite similar to the group A, but generally a bit milder, less severe. And in addition, the group C and group G can also have non-suppurative complications of the streptococcal infection. They may be associated with acute glomerulonephritis, but it has never been shown that group C or group G could cause an acute rheumatic fever. And they can be treated in the same way like group A with penicillin or with clindamycin. A throat culture would show several bacterial commensals, mostly some anaerobes and also some subtypes of Moraxella, Neisseria, Haemophilus, and others. The Moraxella has some importance because it can have a synergistic effect with group A beta hemolytic strep and can increase the severity of the infection. Neisseria is usually a commensal. Majority of the Neisseria are non-pathogenic, but some forms of them, like for example the Neisseria gonorrhea, can trigger a tonsillitis, and Neisseria meningitis, the meningococci, although it's found in 10% of the population, can sometimes cause also some severe infections. Throat swab cultures are particularly important with some infections caused by anaerobic bacteria, including peritonsillar abscess, basically the type 2 abscess. Type 1 peritonsillar abscess are basically formed due to heavy group A beta hemolytic strep. Type 2 have a heavy polymicrobial growth, some of them anaerobes, including Fusobacterium necrophorum, and also some streptococci, which are aerobes. Type 2 is the more severe form of the peritonsillar abscess. The other anaerobes that can cause serious infections in the throat include, for example, the Lemierre syndrome caused by Fusobacterium necrophorum, and this can be a life-threatening condition because of the thrombosis of the internal jugular vein. In addition to Vincent angina, which causes a unilateral gray tonsil ulcerative or exudative membrane, which can be painless and associated with significant halitosis and cervical or oral or pharyngeal abscess formation. It's usually a mixed type of infection formed from spirochetes and fusiform bacteria like Treponema vincenti and others, or Fusobacterium nucleatum and others. Fusobacterium necrophorum, which causes the Lemierre syndrome, is an anaerobic gram-negative bacterium. It causes this potentially life-threatening condition that starts with a sore throat, an oropharyngeal infection, abscess formation in the oral cavity or the pharynx, and a thrombosis of the internal jugular vein. And usually it affects adolescents and young adults. It can be detected as a commensal in up to 7% of healthy controls, but its prevalence would increase to 18% in cases of a sore throat and raises up more, up to 21% in cases of high grades of center score like grade 3 or grade 4. A throat swab culture can also be useful in the confirmation of a Cyanobacterium diphtheria infection. It's quite rare nowadays. It gives the patient a white grayish pseudomembrane, not limited to the tonsils, but involve the surrounding mucosa of the soft palate and the pharynx, and the mucosa would bleed easily on touch. It can be serious and can threaten acute upper airway obstruction and can produce exotoxin as well. Some of them can affect the heart. The diagnosis can be confirmed microbiologically on a throat culture, but it needs to be sent on a special request form for a special culture media. They can also be detected serologically by PCR tests to detect the toxins and the antibodies to the toxin in the serum. And of course, since 2020, the COVID-19 needs to be considered in the differential diagnosis of all new onset acute sore throats or respiratory infections. They have some particular symptoms or signs, including the cough, the elevated temperature, the difficulty in the breathing, and the anosmia, as well as it affects more patients who have been in close contact with other individuals who tested positive. This should be a part of the differential diagnosis, and there are special tests to confirm the COVID-19 diagnosis. The rapid antigen detection tests were developed to detect and confirm or exclude the diagnosis of group A beta hemolytic strep within minutes. Basically because a throat culture requires an incubation period for between 24 and 48 hours. Now this will provide a much quicker way of confirming or excluding the condition so that antibiotics may be started quickly, or a decision not to treat with antibiotics can be reached within minutes. It has a lower sensitivity compared to the throat culture, and it does not detect other forms of streptococcal infections like group C or group G. It's basically designed to detect group A only, but it's still very useful because by excluding the infection by group A, the use of antibiotics had dropped significantly in the patients who tested negative. But because it has a lower sensitivity, it should not be the only way of confirming the diagnosis of group A beta hemolytic strep in areas in which the acute rheumatic fever is more prevalent than in Western societies, for example. A PCR form of the rapid antigen testing was developed with a higher sensitivity that may be equivalent or even superior to the culture. But still, most of the national UK guidelines don't support its use routinely. There is insufficient evidence to support the recommendation of using it for every patient, and also neither the rapid antigen testing nor the throat swab could differentiate between a patient who has streptococci in the throat because he is a carrier or because he has an active infection. And the microbiological throat culture is less expensive than the rapid antigen testing. Its clinical efficacy and the risk stratification of patients with acute sore throat and whether they need antibiotics or not was used in the famous PRISM study, which was a randomized controlled trial in the UK. Patients were tested by two things. One of them was the rapid test, antigen, and the other was the clinical scoring system. And the findings of the study showed that they don't add much information. The use of rapid antigen tests don't add much more information than the clinical scoring tests. So there is no clear advantages for using it over clinical scores alone. The limited additional value of the rapid test may be because they they only identify group A streptococci. They don't diagnose group C or group G, so these would be missed. By using the center score or other clinical scoring systems, with or without the rapid test would just give the same answer. So the use of rapid test was not usually necessary. And that led to the recommendation by the National Institute of Clinical Excellence in 2019 that the rapid tests for strep A infections are not recommended for routine use for people with sore throat, because their effect on improving the antimicrobial prescription is not very great. Clinical scoring system could do just as good with alone or with them, so there is little advantage in using the rapid tests. By this, we come to the end of this presentation on who needs investigations in acute sore throat. Assalamu alaikum.